Everyone. Welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. It's really great to be with you guys today. And in today's episode, we're going to be talking about radiographic interpretation, maybe outside the idea of periodontal disease, right? We want to take a systematic approach to looking at our patients' radiographs when we are doing our assessment, because sometimes, depending on the radiograph that you take, you may discover something that is asymptomatic for your patient that could save their lives. So it's really important for you to keep your eyes open and not get too tunnel vision and hyper focus when you're taking radiographs on your patient, so that you can stay open to the possibility that those radiographs may reveal something that you may otherwise miss. So when we take our medical history on our patient, we ask a ton of questions about systemic conditions. And sometimes our patients will say no on the medical history. That does not mean that it's a no. They may have something that's undiagnosed or has not been revealed yet in their medical history. So you want to be vigilant when you are doing your medical history update or initial assessment of your patient to be sure that you don't miss anything on that assessment. They may tell you that no to Paget's disease, or no to diabetes, or no to having a tooth problem. And then you take your initial examination of your radiographs. Maybe you take a Panorex and a set of bite wings, depending on your patient's age and needs and risk assessment, your initial findings. You take a look at everything and you decide that your patient is not at high risk for anything. So let's just take a generalized look around. And when you're looking at your patient, you want to continue to have the curiosity, right? The curiosity of, is this normal? Are we within the normal limits? And what am I looking at here? Is this just a variant of normal when you're taking those radiographs? We tend to get a little hyper focused on the horizontal bone architecture and the vertical bone architecture. And I know in school, when you're learning about radiographic interpretation, we have you doing all the things. You're looking at the horizontal bone, the vertical bone. You're looking at the interdental space. You're looking at the trabecular bone. What does everything look like? You're looking for all of the landmarks. And the intention for that is to really get you looking at your radiographs in a comprehensive way so that you are better equipped to note your findings or notice a change in something that might otherwise be considered normal or overlooked. Don't get yourself just focused on the periodontal diagnosis and the clinical attachment loss with your patient. Really focusing on the patient as a whole when you're looking at those radiographs goes a long way. So you're looking at, if you find something and you're not quite sure what you're looking at, think about the shape, the size, the nature of the borders that you're looking at. What's the internal architecture? Is it clear? Is it radiolucent? Is it radio-opaque? Does it look kind of cobwebby? Does it look like a bunch of bubbles? Is it what they call uniocular, one circular area? Is it multiocular, where it has a bunch of little bubbles and looks like soap bubbles together? The location and the distribution of these lesions when you do see something is really important. And then how does the surrounding tissue around that lesion respond to what you're looking at? These are very important things for you to consider. When we look at the margins tell us a lot about the biology of the lesion. It also tells us about its aggressiveness. So even if you don't know what you're looking at, and that is okay. Honestly, it's okay if you have no idea what it is. The fact that you notice it is the most important part. So when you have a, if you find a lesion on a radiograph, your job really is to just note that you see it there and then have the conversation with the patient. Find out if they're having any symptoms or if they've noticed anything. Look at the previous radiographs. if this is a patient of record that you've seen before so that you can figure out if it was something that was there before. Sometimes having the previous radiographs goes a long way at helping you figure out the severity and seriousness of this. But the borders tell us a lot as well. When you have a well-defined narrow zone of transition, very slow growing margins, those margins tell us it's usually benign. It's corticated, it's regular and smooth. When you have a lesion that's ill-defined, it has a wide zone of transition, it's kind of blending or it's aggressive. It wasn't there on the last radiographs, and now it's really quite substantial in size. It's non-corticated and irregular. Those are a little more serious. So it's important for you to, if you note something, right, you want to look at that architecture and you want to look to see what those borders tell you. And that's really important. And then the location of it tells us a lot about the type of diseases that are present. So if it's in the maxilla, is it in the mandible? Is it in the sinus or the soft tissues? Is it back around the wisdom tooth, right? And how does the surrounding tissue respond? What's the effect that that lesion is having on the teeth? Is there displacement of a tooth? Is there resorption of the root? Is there a change in the eruption? Is the tooth super erupted? Is it mobile? Right? What does the bone look like? What's the effect on the cortical bone when you look at the radiographs? Is it expanded? Is there displacement? Is it thin? Is it thick? Has there been destruction? So when you start looking at radiographs and you kind of are looking broadly at them and you see something, you're looking at the margins, you're looking at the lesions. Is it radiolucent? Is it radiopaque? Where is it located? Does this patient have any symptoms or aware that it's there? So some of the terminology that's associated with radiopaque lesions, things like focal opacity, target lesion, multifocal confluent, irregular or ill-defined. Ground glass is another appearance. It looks like a lesion with a bunch of ground glass in it, or soft tissue opacity. So those are some of the appearances. Opacity, an opaque lesion. So something I think of that's totally benign, that shows up on radiographs that would have an opaque appearance to it would be mandibular tori. Mandibular tori are really, really large and they show up as opaque. And boy, do they make taking radiographs very challenging. So that would be an example. And that would be a completely innocent thing to see show up on a radiograph. So thinking about location and appearance, and then when you look clinically, that will help you determine whether or not this is something to be concerned about, or is it a variant of normal? Some of the outliers or things that you might notice as a dental provider is when you take a Panorex x-ray, don't look at just the teeth. Or you want to check out the TMJ, look at the sinuses, look at the neck, right? You may catch calcified lymph nodes in those soft tissue areas. You may notice calcification within the walls of those internal carotid arteries, right? You may notice a nodular radiopaque mass below the posterior angle of the mandible. You may notice something that stands out a little different, right? So if someone is predisposed to have a higher risk of a stroke, something may show up on that Panorex x-ray, but you have to be looking for it. So it's important for you to kind of stay focused on some of those things that can show up, right? The radiographic density, the shape, the size, the extent of the internal architecture, the borders, all of these things give us clues. So the borders especially tell us a lot about the biology. So when I tell you that that surrounding bone, when it's intact and encapsulated in those lesions, those are typically okay. And those conditions are usually benign, like I said. But then there's sometimes important things that there is a couple of exceptions to those, like chondrosarcoma, which can be slow growing and cause cortication, but is still malignant. And other exceptions are those punched out lesions. They're uncorticated, but they're well defined and they may prove to be fatal. Those are things like multiple myeloma and histocytosis X. So what's important for you is to note it. Note that you saw something, ask the doctor about it, document your findings, and have that conversation with the doctor when they do that exam so that you can work together to be sure that all of the things are reviewed with the patient. So sometimes a malignant lesion usually destroys the cortical bone in its path, causing little cortical expansion. So sometimes the periosteum is carried along with the tumor and continues to lay down bone in what we call a sunburst pattern. So that's something that would be kind of a standout to you if you see that in your patient. It almost looks like a sunburst, just a star. And then some other things that show up on radiographs, like a ground glass pattern, like I said, those are characteristic of several diseases. So when you see that ground glass appearance, it's important for you to investigate and take note because that patient may have something like hyperparathyroidism or Paget's disease or fibrous dysplasia, and these things haven't been noted yet, or they haven't found out about it. So sometimes you might be that first person that takes a radiograph and notes some findings, and that may cause a cascading effect where that patient then sees their doctor, and we go from there. So at the end of the day, the most important thing I can tell you, you may not know what you're looking at, but look closely at your radiographs. You may discover many asymptomatic lesions. It's very, very common for you to find something, and you're taking the time to do your head and neck exam and try to connect the dots while you're working with that patient. You may discover that the dots align. You may find something out that you would have otherwise not noted on your patient had you not taken that really close look at the radiographs. And at the end of the day, you may possibly save a life just by taking that extra step at looking closely at those radiographs and asking the question of curiosity. What am I looking at here? How is this related to this patient? And what are the signs and symptoms? How does it look? And what do I think it is? And like I said, don't put the pressure on yourself to feel like you have to know what you're looking at. Your job is to point it out, bring it to the attention of the doctor, and work together, collaborate to see if you can't meet the needs of that specific patient and follow the trail to diagnosis. That's really your job. And boy, are we really good at that as dental hygienists. We tend to ask those questions and remain curious because we know our patients and we know when something stands out. Follow your gut. That is the best advice I can give you when it comes to radiographs, is to follow your gut. If you see it and something doesn't look right, say something. You don't have to know exactly what it is. And use your textbooks. There's lots of pictures in the textbooks that will help you. Maybe you have a couple of minutes while you're waiting for the doctor. Pull up your phone and take a look and see if you can't figure something out that way. Use your resources to really support your evidence and your information gathering process. All right, guys, I hope this was helpful. Keep looking at those radiographs in a comprehensive way because it shows us things that we cannot see clinically, and it sometimes shows the patient things that they don't know what's going on either. So it's all about closing the loop and connecting the dots. Have a good week.